And when you're looking in the mouth, do you ask them to stick their tongue out or keep their tongue in, say ah? Do you do it with the tongue depressor, without the tongue depressor?
There's the Mallampati score, which was popularized by anesthesia to predict ease of intubation and modified by Friedman into the Friedman tongue position score. And both of those are supposed to be opening your mouth with your tongue in its normal position. However, I can do that for you and show you a Mallampati 4 airway, and then I can do it again and show you a Mallampati 1 airway. And I think it has to do with the way that you activate your tongue muscles, and some people relax their tongue and some people don't. So I try to get a good look. I tell them, put your tongue back in your mouth and just open your mouth. Try to relax your tongue. Try to say ha, 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 and that elevates the palate. Usually they relax their tongue. If they can't do it, then I just got to see if they have tonsils or not, or what's going on with the tonsils. I take a tongue depressor or 2 tongue depressors, and I jam on their tongue with it, and I just look.
It's always been, even as a resident, and maybe I'm always been a contrarian or always thinking of a better way to do things, but it never made sense that we're examining these people sitting upright. That's not how we sleep. So I always thought those classifications were funny. I mean, and even our anesthesiologists look at the patient in the bed in the pre-op area kind of at a 45-degree angle. Well, that's not how you're going to intubate them. If they're going to do that, I feel like they should be laying flat at least, even though they're still awake. So they have more muscle tone than if they're in deeper sleep. I find the same thing, Ashwin. It's hard to predict. It's how they hold their tongue. It's how much of a anticipatory gag reflex they have. I mean, it's a very inexact science.
I put a lot of my weight on my exam during a drug-induced sleep endoscopy.
Right.
I do a much more detailed exam with the patient anesthetized with propofol regarding their airway, especially if it's a patient who's never had a sleep study, never been on CPAP. I know that we're going to go through all those things before I do any surgery, probably. So just in my practice, the sleep endoscopy is basically the jump off point for any CPAP alternatives. If you're coming in and you've tried CPAP and it's not working for you, then we're talking about doing a DICE.
Whether or not you're considering Inspire, you're just doing it anyway.
Yeah, that's what I'm going to do for every single OSA patient who isn't tolerating CPAP. That is how I evaluate for mandibular advancement devices, which we make in the clinic. That's how I evaluate for any type of tongue-based surgery.
How is that reimbursement? Or are you doing concurrent procedures like, for example, the Vivere, or how are you getting that paid?
I'm really curious. Actually, I mean, I live in a strange insurance microcosm that is very different and almost certainly worse than yours, called Alabama. So, I've never been denied a septoplasty, and I'm sure I will be now that I'm saying this.
United Healthcare is listening and already taking notes on you, so good luck.
Yeah. But anyway, I have never been denied a sleep endoscopy either. So basically, if somebody has OSA, I document in my note that they have obstructive sleep apnea, that they're intolerant of CPAP. We book the sleep endoscopy. So if we're going to get into the financials of it, it reimburses well enough in a ambulatory surgery center in my environment that they want me to do as many as possible. It reimburses so well in the hospital that they want me to have a whole day in the endoscopy unit where that's all I do. The surgery center wants me to bring it there. The hospital says, we really want you to bring it here. And that's just DICE. The way that I speak to patients about it is, we are going to try and see what we can do to treat your OSA other than CPAP. And I'm just going to go and look. I'm not going to guess. We're going to go and look and see what pattern of collapse your airway has. And then I'm going to wake you up and send you home. And then we'll come back to the clinic and we'll talk about it. Now, also, if you have nasal obstruction, we can treat your nasal obstruction at the same time, whether that be radiofrequency, whether that be operative septoplasty and turbinectomy, or whether that be functional rhinoplasty, whatever it might need to be. But if we treat your nose and then I bring you back to the clinic and I explain the sleep endoscopy findings and you don't like what I'm telling you, or there's not a great option that suits you and me, or I really just don't think there's a really good way to treat your severe OSA, then by doing the nasal surgery, we've teed you up to succeed with CPAP. We'll give it another shot. And if there is something else, then treating your nasal obstruction will only help that succeed better. So of all the things I offer in my clinic, whether that be sleep or ENT wise, I'm very aggressive in offering nasal surgery or nasal treatment to patients with OSA because I feel like it's very safe. It's pretty much going to help them one way or another. And they've been appreciative.
Yeah. So your DICE patients already have had a sleep study. These are patients that already have a diagnosis of OSA.
Yes.
I'm just curious, how is your reimbursement? So I know the facility fees are good for the hospital, and
It's awful.
yeah. So I mean, how do you feed your family if you did a whole day, for example, in the hospital?
Thyroids and sinus surgery.
That's the reality, right? I mean,
Yeah. Logistically, what we do is I've been lucky enough to get endoscopy units. So I run a full OR day, but I can also do 6, 7, 10 DICEs in between cases.
Okay.
So I'm not picking, do I do a DICE or do I do a thyroid, parotid, vest, whatever it may be, ear tubes, tonsils, whatever. I do both. And the OR is moving and the endoscopy unit's moving. So it's not a great moneymaker. We were doing it in the clinic with an anesthetist that would come to clinic, but reimbursement wise, there's no code for it. So you're just getting a 31575, which is the flexible laryngoscopy, which pays what it does in clinic, same as on an awake patient. So I'm not going to say it's a waste of time, but it's not the best use of time.
It's not economically viable. Yeah.
Correct. Coupling it with nasal procedures, though, saves the patient a trip under anesthesia, gets diagnostic data, and does some therapeutic intervention, and then it will pay a lot better too.